Welcome, everyone. We're happy to have you join us today for a presentation by Dr. Paul Song, The False Promise of the Public Option, and other distractions that get introduced into Congress every now and then. Some of those there are some things that might actually be a step towards universal health care, and then there are other things that I think are used to distract us from that prize of the universal single-payer healthcare that meets human rights standards. Dr. Song is a radiation oncologist working in California, and he's also the president of the California Physicians for a National Health Program. We are extremely pleased to have him here because he is so insightful into the political aspect of a lot of our healthcare system woes. And he is the one that he helped me get back on track one time. I was upset that my younger brother managed to get Medicare before I did, and he got it because he was disabled mostly through his own doing. And Paul pointed out to me that that's by design. The system is designed to do that to us and to pit us one against the other. So we really need to work to ensure that we don't do this. It's not a question of whether people deserve healthcare or not. It's a question of all of us getting what we all deserve. So welcome, Dr. Song.
Well, again, thank you so much for having me here, and thank you for taking time on your Saturday to tune in. First and foremost, the slides that I'm about to present, I will make available to you all so that you can peruse them at your leisure if you'd like, share them, use them to spread what I call the Medicare for All gospel. But really what I would like to do today is to just give you a lay of the land of where things are currently in our country, what COVID sort of exposed about the fallacies of our current healthcare system, and then really talk to you a little bit about what the public option is and why the facts show that it won't really address the issues that I'm about to point out. So let me just start with my, okay. So, it's hard to believe now, it's been 12 years since the Affordable Care Act was signed into law, and it's meant a lot of different things to a lot of different people. As you heard, I've been a radiation oncologist now for over 25 years. And probably early on in my practice, the thing that I started to see was particularly people who had had long-standing histories and battles with cancer were pretty much up against the end of their caps. So up until the Affordable Care Act, if you had a chronic illness, a lot of your insurance plans, after it paid out over $1 million, no longer covered anything. And for people that had, say, been battling breast cancer for 10 years, they were pretty much out of options there. So there are some good things that the Affordable Care Act did. It did away with these lifetime caps, did away with using pre-existing conditions as a way to have people pay more for their premiums. It tried to address the Medicare Part D, the prescription drug part for Medicare, but certainly there were some other issues that it didn't go far enough. But this was now 12 years ago. Now, during the time of the Affordable Care Act, the Lancet, which is a very reputable journal, medical journal, dedicated an entire issue to the Affordable Care Act process. And in it, they said the healthcare reform process exposes how corporate influence renders the U.S. government incapable of making policy on the basis of evidence and the public interest. And what they meant by that was there was 3,300 registered healthcare lobbyists for the 535 members of Congress. They were spending more than $1.2 million a day. More was spent on lobbying Congress than was spent on the entire Bush-Kerry election. And as a result, Congress being so beholden to the private insurance industry, pharmaceutical industry, hospital associations, there was no public option, no insurance rate regulation, and no drug pricing control. And when you think about the areas that are really the most continued detrimental areas of the Affordable Care Act, it's these particular things that were basically prevented from happening because the lobbyists really won. And just to refresh your memory, you heard Bernie say it a lot during the primary, but we do spend nearly twice as much on our healthcare per person as every other industrialized nation. And yet, if you look at our life expectancy, we have a lower life expectancy. And in fact, COVID further reduced the life expectancy in the United States by over a year this past year. The other thing is, if you look on the right, as I mentioned, we spend almost twice as much, if not more, than certain countries per person. And then down below, if you look at the number of people that are having financial difficulty as a result of this, it's significant. So, by every metric, we're not getting what we pay for, and especially with the lower life expectancy. This is just to point out that, and I'm sure many of you who received your coverage through an employer, perhaps through a union, things of that nature, this is just showing you that from 2009 till now, a couple things. So on the front end, each month, probably more and more of your paycheck was being taken out to help subsidize your employer-sponsored healthcare. And while your wages remained stagnant. So on the front end, there was less in take-home pay every month. And then if you did get sick, the amount that you were asked to contribute in terms of co-pays, deductibles towards your prescription drugs increased as well. And it's no wonder that many of us and many workers were stuck in jobs that they didn't really like, but they stayed in the jobs solely because of the employer-sponsored healthcare coverage. Meanwhile, wages remained stagnant, whereas inflation remained pretty stable over the course of 20 years, but premiums just continued to escalate. And in terms of what we were asked to contribute, continued to escalate. So the idea that somehow employer-sponsored healthcare was great is simply not rooted in fact. And if you look at what a Medicare for All system would do, it would probably cause wages to escalate dramatically, because employers would no longer have to focus on fighting employees over healthcare benefits, because it would all be covered. The other thing is to point out that the Affordable Care Act for many has not really been affordable. If you look on the left, it just shows you how much people have said that it became progressively more difficult to pay for their health insurance each month. Became more difficult in the middle column to pay for co-pays or deductibles or prescription drugs. And again, this is just showing you that despite the fact that the Affordable Care Act has now been law for 12 years, that more and more people are having financial difficulties. So it is anything but affordable for many of us. The other part to point out, and you'll hear sort of corporate Dems and also Republicans say that they want to give everyone coverage, meaning they want everyone to have private insurance. And this is just to show you, particularly if you've got one of those plans that has a high deductible, that 1 out of 3 people in the United States reports that they delayed seeking care because they couldn't afford their copays or deductibles. So let's say one of you has a plan that has a $7,000 annual deductible. What that means is the first $7,000 of all your medical expenses has to be paid for by you before insurance starts to kick in. And then for many of these high deductible plans, once the insurance plan actually kicks in, it only covers 60% of the plan. So let's say you felt a mass in the side of your neck and you wanted to go get an x-ray and had to go get a biopsy. Many people have plans that the first bulk of that has to come out of your own pocket. And if you don't have that kind of money sitting around, guess what? A lot of people delay seeking care, and it's 1 out of 3. So I think when you hear a politician say they want everyone to have coverage, that doesn't necessarily mean they want everyone to have real access to healthcare, because some of the insurance cards that people have aren't really worth the paper they're printed on. And let's not forget that prescription drug prices are so high that, and Medicare is prohibited from negotiating drug prices, that this was back in 2017 that 45 million Americans reported that they didn't fill a prescription because of the cost. And 1 out of 5 seniors says that they don't fill all their medications because of cost. And recently I heard a piece on NPR about somebody who couldn't afford their insulin, and they were basically spreading out the insulin over a period of time rather than taking the amount that they needed each day, and subsequently died of diabetic shock. These are the horror stories that you hear. And the other sad part is a lot of drugs are meant to be taken with food, but if you have to figure out between paying for your drugs or paying for your food, you really sometimes can't take it the way that it's meant to be. And this is a major, major problem in our healthcare system. And the other thing I just want to point out is this something called narrow networks. And what that means is if you, in your specific area, a narrow network is defined as if the insurance plan only allows you to see 25% or less of all of the doctors that are in your area. And if you see most of the plans that are out there, particularly some of you who are on Medicare Advantage plans, you'll see that your choices are very, very limited. So my mom is 89. She's been on Medicare, traditional Medicare, her whole life. My late father worked for Exxon, and my mom was getting supplemental insurance from Exxon. This year, they unilaterally told her that they would have to move her into an Aetna Medicare Advantage plan, and it's dramatically ruined her access to care. She developed back pain, and she had to wait 3 weeks to get approval to see somebody, only to find out that the person that was in that book that they sent out was really not even in their network. And majority of the doctors that I actually work with in this neighborhood, she was not even able to see them because they're not in her network. So we have this convoluted healthcare system right now, meaning, let's say some of you last year were getting your coverage through United Healthcare. Your employer decided this year that the premiums were too high and they were going to switch to Aetna. And maybe next year they switch to a Kaiser plan, or you lose your job entirely, and now all of a sudden you're scrambling because you can't afford your COBRA payment, and now you've got to go on your state Medicaid system. Or some of you turn 65 and you move into a Medicare program. The problem is when you go to a doctor, they've got to figure out, am I still in your network? Who's your coverage? What's your copay? What's your deductible? Hospitals have to figure this out. And all of this complexity is actually taking energy, time, and resources away from actual patient care and putting it away in terms of this nebulous administrative waste. And this is really at the core what's wrong with our current healthcare system in terms of the lack of efficiency and the constant sucking of profits and administrative waste away from actual patient care. And just to point out that if you look up above, between 1970 and 2015, the number of physicians that were trained is the green down below. But if you look at the number of healthcare administrators that have been brought on, it's been an explosion. And down below, if you look at the change in health expenditure, look at private insurance from 1980 to 2010. The top curve sort of mimics the number of hospital administrators or healthcare administrators, and you wonder what the correlation between all of a sudden this explosion in costs in the private insurance industry and all these administrators. And ultimately, if you look at when Medicare was privatized, it's around that time, and they're all designed really to maximize the system, but this is all adding these complexity and cost to a system. And if we simplified it, perhaps we wouldn't need so many administrators, and we could actually use more of that money to actually take care of people rather than pay for exorbitant CEO salaries, all of these people that basically are on a phone just to deny our care. And it is so bad right now that administrative costs represent a larger share of our healthcare spending in the United States than any other country. Again, look at all of the administrative percentage of our healthcare that's going to administrative costs compared to all of the other industrialized nations. And it's so bad that Duke University actually has more billing clerks than it does hospital beds. And again, if you look at how much a hospital spends on administrative costs, 25% of their entire budget is on administrative costs. Well, if they had a simplified system, they wouldn't have to spend so much of their budget trying to fight with insurance companies to get reimbursed. And if anything, they could use more money to add more ICU beds, which we saw was a problem during the pandemic, add more ventilators. All of those things could be really, money could be used elsewhere. And here's another area that, as we have an aging population, long-term healthcare is another big problem. But look at how much we spend, again, on administrative costs on the left, but how much we spend on long-term care. And one of the issues of Medicare for All, and I know Bernie has addressed it, is not only do we need to make sure that we can provide coverage for people that are acutely sick, but we have to really come up with a solution to cover long-term healthcare costs. So my father-in-law had some real serious issues. It looked like he was going to be placed in palliative care. We put him in a assisted living facility. Insurance only covered a portion of that. To pay for one-on-one care and everything is quite expensive. And I would imagine most of our country would run into a major problem with that, and is running into a major problem with that. So if we could, again, take some of our waste away from the administrative side and implement a policy and plan to provide better long-term care, wouldn't that make sense? But this is just showing you that there is money there to be able to do that. So it's no wonder that we have the least efficient healthcare system in the world. The Bloomberg World Rankings, we're not even listed on that in terms of a healthcare system. And then one of the other things you hear about is Medicaid. Now, I know in Ohio, you guys have successfully moved to expand Medicaid, but many of the other states still are staunch against it. But just to point out that Medicaid is really an unequal apartheid system, and I'll show you why. Here in California, where 1 out of 3 people in the entire state is on our Medicaid system, which we call Medi-Cal, it's been highlighted as being separate and unequal. COVID certainly exposed that. There's been long delays for patients who are on Medi-Cal to see doctors, and it really is, again, not worth the paper that it's printed on, but it's certainly better than nothing. If you look at how the various reimbursements for providers are, in California, we're 48th out of 50 states in terms of how we pay doctors and specialists. And as a result, so few doctors take Medi-Cal patients or Medicaid patients. And as a result, if you are sick and a Medicaid patient, it's hard to find a doctor to see you. Ohio is not much better. You're 40th out of 50 states. And this just highlights some of the issues that the LA Times did over the pandemic, that here you have a patient with a urological condition in 2015, took them 234 days to be referred to find a urologist that actually would see them. This is another patient that had a brain tumor that took 312 days to actually get the surgery that they needed. And the challenge is that Medicaid reimbursements are traditionally very, very low, much lower than Medicare. So a lot of doctors would actually lose money taking care of these patients and refuse to do so. So the network for Medicaid patients is even narrower than it is for people with the worst private insurance. And again, there's been a lot of stories that have just exposed the shortcomings of Medicaid. But meanwhile, the LA Times found that here in California, the private insurers that are administering Medicaid plans walked away with $500 million in a year profit. So regardless of the system, the private insurance industry does find a way to make lots of money at our expense. And then as far as hospitals, this is just to show you 2 of the preeminent hospitals in Los Angeles, Ronald Reagan Hospital at UCLA and Cedars-Sinai. despite the fact that they have a large percentage of people of color and disadvantaged people in their community, see very little of them. And if you look at Martin Luther King Hospital, 75% of their revenue comes from the Medicaid patients, whereas Cedars-Sinai, it's only 10%. That these hospitals, many of them are, which are not for profit, really do exclude the most vulnerable patients and are not doing the community benefit that they claim they are. And it's no wonder here in California that the Mexican American Legal Defense Fund sued the state of California, claiming that Medicaid is separate and unequal. And a judge finally allowed this to move forward because it really is an apartheid, unfair system. And I would argue Medicaid in Ohio and everywhere else is really no better than it is here. So let's just share a little bit about COVID. We just passed 613,000 deaths due to COVID in the United States. And, what I worry about is with all the deaths that we become numb as a society to how many people succumb to this. But with the Delta variant rising and the people failing to be vaccinated, it's still very much a problem. But COVID really has exposed a lot. There was a Lancet Commission study that came out in September of last year that found that 40% of all USA related deaths could have been prevented, that 1/3 of those people who died of COVID here in the United States were uninsured, that 40% of the people that developed COVID were uninsured. And I just want to show you how COVID exposed all of the shortfalls of our healthcare system. So during the the Democratic primary, you had then Vice President Biden slam Bernie as saying, look at all the countries that have a universal health care plan, their death rates are so high. And this was, if you look early on in pre-June. But since that time, what's happened is the deaths in the United States have exploded, whereas in the countries that did have a universal healthcare system, they did a much better job of keeping their death rates under control. But in the beginning, remember Italy, the infection was running rampant, and Biden was using that as an example to say that a single payer or a universal plan wouldn't work. The other part was you had Amy Klobuchar slam the Bernie's plan as saying that you want to kick 100 million people off their employer-sponsored healthcare. Well, guess what? The pandemic did that. Roughly 14.6 million people lost their employer-sponsored healthcare because of the pandemic. And let's not forget who the frontline workers were, right? These are construction laborers, cooks, truck drivers, cashiers, waiters, waitresses, and they are the largest percentage of people that are traditionally uninsured. And you had these people on the front line with no insurance getting infected, and it's no wonder our death rates were as high as they were. But let's look at the number of people in other countries who lost their employer-sponsored healthcare during the pandemic, 0. So I'm sure many of you believe healthcare is a human right, not a job perk. And the other thing that you heard many people say about a single payer plan is it would lead to rationing of care. Well, the pandemic exposed that. So some of our poorest hospitals, again, because they didn't have the resources to build out their ICU, have enough ventilators on hand. Los Angeles, where I live, actually was rationing care. Hospitals were diverting patients, and they had to decide who would get a ventilator, who wouldn't. So every lie that we've been told about what a Medicare for all plan would do came to fruition with our current for-profit immoral healthcare system. But here's who did well during the pandemic. You hear about all of the online companies like Zoom and Amazon and such, but certainly the health insurers did quite well during the pandemic. They had record profits. And during the pandemic, it became clear that when people were asked, particularly many people who had lost their employer-sponsored healthcare, should Congress pass some temporary law that if you lost your employer-sponsored healthcare and you couldn't afford your COBRA, should they allow you to just enroll in Medicare right now during that, and there was overwhelming support for people to be given emergency Medicare. Instead, what happened was the corporate Democrats passed a bill, signed into laws to the stimulus that basically gave billions of dollars in subsidies to go buy your COBRA insurance, again, to keep the corporate welfare going for the private insurance industry. But there was an appetite during this pandemic for more people wanting Medicare. And just to point out where we are right now, the number of uninsured, this was pre-pandemic, was starting to spike up, certainly between the attacks of the Trump administration on the Affordable Care Act and such. But the uninsured rate was creeping up slowly in the United States prior to the pandemic and has only gone up since the pandemic. So just to highlight again the problems of our current healthcare system, we have somewhere between 31 and 33 million uninsured people in the United States. We probably have another 50 million that are underinsured, meaning the copays, deductibles, premiums are too high that people don't actually use their healthcare, or if they had to, they would probably go bankrupt because they don't have the money to pay for the additional amounts. We have no coverage for our undocumented brothers and sisters. There's still no insurance rate regulation, no drug pricing control, narrow networks remain. Many people have high copays and deductibles. We have all this administrative waste. We have an overall inefficient system, and there's still no security with job loss with our current healthcare system. So I would ask you to just keep all these problems in the back of your mind and say, does a public option address any of these? Having said that, there was a poll that was done right around the presidential primaries, and they were asking, would you be more supportive of public option or Medicare for all? And the majority of the people still, and again, I would claim they didn't really know everything about it, were in favor of a public option. But just to point out, there's still overwhelming support now for Medicare for all nationally. So the key features of a public option, it would be a government administered plan that would compete with all of the private insurance plans on the marketplace. There would be subsidies and cost sharing. You saw as part of the stimulus bill, there has been a dramatic increase in the amount of subsidies. Up to now, if you got your coverage to the exchange and were making more than 400% of the poverty line, you weren't eligible for subsidy. But not only have they increased the subsidies for the people making less than 400% of the poverty above the poverty line, but they've increased subsidies for everyone. So they're trying to make the insurance more affordable, but it's just crazy. So the insurance industry can just continue to jack up the prices, knowing the government is going to pay a little bit more, rather than if the government administered that and saved all that savings that went for profit and such, we could insure everyone and give everyone better benefits. But this is the basic premise of the public option. So I just want to point out 1965, yesterday or the day before was Medicare's 56th birthday. I was born 2 weeks before Medicare. That's me and my dad on the left, and that's Lyndon Johnson signing into law. And you can see Harry Truman, who was probably the first real pusher of Medicare for all bill. And just to point out, when you hear people say the government is incapable of doing anything, as well as the private sector, this is just to show you that Medicare generally takes care of poorer, sicker, older people, showing that most people on Medicare have chronic medical conditions, up to 30% have cognitive mental impairment, up to 30% have fair or poor health. And despite the fact that Medicare takes care of really the most vulnerable population, it still does a much better job of controlling costs compared to the private insurance industry. So if you look at the growth of spending from 2007 with private insurance, it's nearly double what Medicare and Medicaid have done. So when you hear that, and this is not, this is despite the fact that Medicare is not allowed to negotiate drug prices or discounts on bulk medical supplies, but in spite of that, people in Medicare have a much greater patient satisfaction than private insurance. Now, what's happening with the privatization of Medicare is you're starting to see a little bit of the popularity go down a little bit, Some of you may be in good Medicare Advantage plans, but there are others like my mom who are in plans that really put them back into the private insurance world of limited choices, denials, and all of the issues that are associated with that. So I would argue that instead of this convoluted system that I pointed to before, if we just had one single payer, we could save dramatically on administrative costs, administrative waste, make our system more efficient, and use those savings to bring up the benefits for every current Medicare beneficiary. I know Bernie right now is trying to improve Medicare to include dental, vision, and hearing aids, but also do away with the 20% Medicare Part B cost sharing. So if we were able to simplify it, there would be a lot of savings there. Plus, if Medicare was then allowed to negotiate deep discounts in drug prices, why is it when United Healthcare uses its market share to negotiate deep discounts for its 100 million subscribers, it's considered good business sense or good free market principles, but when Medicare tries to do it, it's considered government interference? Well, we can do that for Medicare for All plan. And one of the things you will hear is that a Medicare for All plan is too expensive. Certainly Fox went to town, and a lot of corporate Dems during the primary said we can't afford it. And this was based on a study that was done by the Mercatus Institute at George Mason University that analyzed Bernie's plan and said it would cost $32.6 trillion. Ironically, when Fox and Friends did a poll, would you support it? 73% of all their viewers said yes. But here's the part that's dishonest about this. The Mercatus Institute did indeed show that the Bernie plan would cost, the amount that I mentioned, but it would do so by insuring every single person, increasing the benefits of every senior. But that if we did absolutely nothing, a traditional current status quo would cost more than what a Bernie plan did. So now, not only would a Medicare for All plan save money, but it would insure everyone and increase everyone's benefit. But you didn't hear anybody, any Republican pundit or even any corporate Dem be truly honest. They just said it would cost $32 trillion, but they didn't point out that it would save $2 trillion. Meanwhile, a public option was just found. Somebody did an analysis. This is the team from Stanford, that it would cost $700 billion over the next 10 years. So here you have a Medicare for All plan that would cover everyone, increase the benefits for everyone, reduce drug prices, do away with copays and deductibles, saving $2 trillion over 10 years, whereas a public option would just add one more additional layer of complexity and cost $700 billion over the same 10 years. So just to summarize, the big differences is a Medicare for All plan would cover everyone, whereas a public option would still continue to exclude our undocumented brothers and sisters. Medicare for All would not be tied to employment, whereas a public option does not eliminate employer-sponsored coverage. Medicare for All would eliminate copays and deductibles, would give you more choice of doctors because you do away with the narrow networks. It reduces federal spending while insuring everyone, whereas a public option would add more complexity to our budget, as well as adding $700 billion in costs over 10 years. Medicare for All plan would eliminate administrative waste and costs, and you would be able to negotiate deep discounts in drugs and cost of services. So hospitals would no longer be able to charge $50 for Tylenol, and you could really use the bulk purchasing power of every single American to get big discounts for drug prices here in the United States. And a public option would not address any of those things. Now, some of you may know that during the 2016 Democratic primary, I got myself into a lot of trouble. I was speaking in New York at a Bernie Sanders rally. I used an unfortunate term to refer to members of Congress who were bought by the insurance industry and the pharmaceutical industry, and it created a complete firestorm. Everyone accused me of calling the secretary this term, which in all respect to her, I would never even do, but that's how it was spun. If any of you were offended by the term, I deeply apologize to you, as that was never my intent. But just to point out what I meant by that, this was a study that came out recently that showed that of the 130 Democrats who did not back Medicare for All in the House, that they all received $43 million in donations from the pharmaceutical industry, private insurance industry, and the hospital association. And just right after the Democratic primary, the Partnership for America's Healthcare Future, which was a front group created by health insurance, pharmaceutical, and lobbying groups to oppose Medicare for All, announced that they would start a new campaign to undermine the public option. And this organization was basically run by former top Democratic congressional aides. It just said, within 24 hours of the launch of the industry new ads, anonymous Democratic congressional sources were telling The Hill that Democrats were not likely to bother with a public option fight next year, even if Biden won the election. So just to show you, while I'm not a fan of the public option, we already have corporate Dems that are selling out people and their constituents in favor of the private insurance industry and the pharmaceutical industry. So while people were offended by the term I used, I do believe that the sentiment is echoed in the proof that I just pointed out to you, and that I wish more people were outraged at this than the term that I used. Finally, I'm just going to say this about Shirley Chisholm. So my mom actually came to the United States in 1951 as a refugee during the Korean War. She would eventually graduate from Columbia Teachers College, and the first person to hire her was Shirley Chisholm. Now, Miss Chisholm, before she ran for Congress, was the educational director of several inner city preschools. And as many of you know, then Miss Chisholm became the first Black woman elected to Congress. She then ran for president in 1972 under the mantra of being unbought and unbossed. She said this in 1972, "We have never seen health as a right, has been conceived as a privilege available only to those who can afford it. This is the real reason the American healthcare system is in such a scandalous state." And unfortunately, this quote is more relevant today than it was in 1972. And part of the problem is, again, we have too many politicians who are bought and bossed and not working for us, but really working for special interests. And I would say that even if we had a Democratic supermajority, which we did during the Affordable Care Act, right? We had President Obama, we had 2/3 majority in the Senate and a majority in the House. We still didn't get the coverage we needed. It wasn't Republicans that were blocking Medicare for All. It was the corporate Democratic wing. And what we need to do is really continue to educate, spread the gospel, and then elect people that can help bring about the change that we need. So just wanted to thank you for your time today. Again, I'll make these slides available for you so that you can really look at them more at your leisure. I know I went through them pretty fast, but if you have any questions, happy to answer them.
Okay, thank you so much, Paul. That was really informative. Your slides are great. And I have, from previous slideshows, I've used several of them when I've been doing presentations. We do have one hand up, and that's Bob Crazen. And Bob, can you see if you can unmute yourself?
I can do that.
Okay.
Well, thank you for the presentation. I thought that was really excellent. I suppose I would add one more group to your list of villains on opposing healthcare. Maybe it's sort of accidental, but it is the for-profit media, television and radio, as another obstacle to this, because they receive all this money from health insurers and hospitals and drug companies. Do you want to comment on that portion of it? I know that.
No, you're absolutely right. And again, thank you for pointing that out. I should add that to my talk. I know Wendell Potter speaks a lot about the corporate media, and certainly will. Yeah, you see all these pharmaceutical ads on TV, and but definitely I need to add that to this talk.
We have a question that came through email, and it says, "I'm a physician member of Ohio Span Network and PNHP. I'm also related by marriage to Samuel Ocean."
Oh,
did I say it? Or Oskin or whatever. My question is, my colleagues and I are concerned how we'll be able to earn adequate income from a Medicare for All system. Will the Medicare tax be able to sustain health institutions along with the professionals who staff them, i.e. the physicians who are still in private practice and not on the payrolls of large institutions?
So I would say that there are some doctors who can opt out and not choose to take any government-run insurance. Certainly we see that now in California. There are some doctors who refuse to take Medicare and only are taking private insurance or cash pay. That's the prerogative of physicians to do that. But the majority of physicians who see everyone will actually do better, because I will say this, for my old practice, I was paying people a lot of money to be on the phone all day, fighting with insurance companies on copays and denials and things of that nature, or getting authorization for them to see me. I was spending the average doctor spends 20 hours a week fighting on pre-authorizations, and that's 20 less hours that we can actually take care of patients. That's the average doctor spends somewhere between $70,000 to $110,000 a year per physician in their practice, hiring somebody to go fight to get reimbursed. That all goes away under a Medicare for All system. So while the reimbursement may be per patient, may be a little bit less than what it would be, the administrative hassle and waste would be far less. So you would actually come out ahead. And then because you're not spending 20 hours a week on the phone fighting with a case manager, you actually could see more patients in that period of time. So I actually think physicians would have a better quality of life, far less administrative costs in their own practice. And most analysis show that at least the primary care physicians, pediatricians, internists would actually make more, and maybe some of the specialists might make a little bit less. But as a specialist, I still think it's a much more humane system, and I think it would be something I would aspire to far more, even if it meant making a little less.
Next up, I think we have Bill Davis with a question. Go ahead, Bill.
Hi, Paul. Thanks for joining us today. It's been really interesting. I was wondering, I found an article that said about half of physicians support single-payer healthcare system, according to a LinkedIn survey in 2017. With the pandemic, do you think more doctors have rethought their view on single-payer or universal coverage?
It's a great question. So it's a generational divide. I would say, so I graduated medical school in 1991. So I've been in practice for quite a while. The people that graduated before me, they were used to practicing medicine at a time. And even early on, maybe the first 5 years of my practice, where doctors could do whatever they wanted. Doctors were treated like kings. And I think for those people that practice under that, they will never support Medicare for all. They are very much entranced in the I am God complex, and they can, they were used to billing whatever they wanted, get whatever they wanted, pick whatever insurance they wanted to participate in. What's happened, though, is over the last 20 years, the doctors that have come into the system have never practiced in that system. They've only practiced in a system where you have somebody who's never taken care of a patient telling them you can't do that, order that test or carry out that procedure, because and the decision has been based on cost rather than what they were taught during residency. And the whole new wave of physicians that are actually in medical school right now, or have just come out of medical school, are some of the most altruistic, incredible people that I've seen. The young generation who never practiced when it was gold and they were making ridiculous amounts of money, charging whatever they wanted for procedures. They just have now gone into medicine because this is what they felt a calling to do. And it's not to say that the older generation didn't feel the same calling, but they had a much simpler practice. Now, most physicians, when they come out of medical school or residency, are going to join a practice that's already owned by a hospital, because the idea that somebody can just have their own single shingle practice is almost impossible now. Between the insurance industry becoming so powerful and hospitals becoming so powerful, doctors have to choose: do I just sell my practice and join a hospital and become an employee, or do I join a big practice to fight off the insurance industry, that autonomy is no longer there. So I do think that a Medicare for all system would allow people to go back to being their own boss. At the same time, a lot of the physicians that have been resistant to this are all retiring or passing away, and you're seeing this generational shift. So I think in the next 5 or 10 years, you're going to see much more overwhelming support among healthcare providers for Medicare for all. You're seeing it now, and certainly the younger, new graduates from medical school and residency, they're overwhelmingly in favor of Medicare for all. So that's what's happening. There's a generational divide, and it's changing now.
Very good. Next up, we have a question from Kevin Hinchhold. Go ahead, Kevin, if you want to unmute yourself.
All right, thanks. Yes, I really appreciate the talk today. I guess I'm kind of curious. I feel like most folks on the call are probably on board that, single payer is the right way to go. I was looking over data, and like pretty much everybody across their demographic supports it. Republicans are a little bit wonky. Also, I'm kind of curious about the cost. Like when you look at the public spend on healthcare, regardless of total, we still spend 160, 170, 180% compared to the US or UK, Canada, Australia. So I'm kind of surprised that talking point isn't going out there. But then the question I meant to ask is like, since we're on board and it seems like lots and lots of people are on board, and yet we can't even get like Schumer and Pelosi, let alone McConnell, to come on board. Like, where is the leverage? Where are the choke points? Where can we twist arms? Because I feel like popular opinion is not going to push this across the line.
A great question, and that's really the harsh reality, and that's why I think that if you look at like the race that's happening right now, right, to the Nina Turner's race, the corporate Dems have poured in millions of dollars to defeat her, and much the same way that when Cori Bush won in Missouri, and you had Elliot Engel defeated by Jamal Bowman. It's going to take real primaries from the left to get people in that are ideologically pure on this issue. One thing you learn from the Tea Party and what's happened with Trump is it's pushed people in their party to adhere to these crazy ideologies. And I think we need not to implement crazy ideology, but to have our moderate corporate wing, in much the same way, fear a primary and start to vote for their constituents rather than their special interest.
If I can add something to that, it's been estimated that we need about 3 to 3.5% of the public to be actively behind us and working for this. Now, that doesn't mean posting on Facebook. That means picking up a phone and calling the people that are currently elected and letting them know where you stand and where you expect them to stand in their representation of you. Too many people will not do that, or they think that, well, I called them last year. No, you have to call them once a week. Make it a weekly thing that you call them and let them know. You have to bug them like there's no tomorrow. I usually say you need to be the burr up their butt in order to get them to do that. But until we get that critical mass of people that are willing to do that, it's going to make it difficult. Now, we saw that when Healthcare Now did a program to get Representative Kennedy on board in Massachusetts. They were out in the parking lot of his office building, and they were stopping people on their way in. They had cell phones, and they had these people call. And after an afternoon of doing that, they got so many calls that he signed on to the bill. We have 3 reps here in Ohio that have not signed up. They have in the past. They always had in the past. Marcy Kaptur, Tim Ryan, and Joyce Beatty. If you're in their districts, on Monday morning, you pick up the phone and you call their offices and let them have it.
Is it cool if I ask a quick follow-up?
Sure.
Yeah. So where do you see labor action working? Like I asked because, you watched the West Virginia teachers strike, and they were able to get something done that no amount of advocacy could do. One of the government shutdowns got broken down when the flight attendants refused to get on, let the Congress people fly home. Like, it seems like labor can be a real leverage point that we have against the elites and the rich people. How do you see that working into this campaign?
Labor has to be a big part of this moving forward, but the problem is we've seen in California that a lot of the unions are conflicted. They're serving two masters, and some of them have these great Cadillac plans and they don't want to give it up. But in the end, they should take a step back and look at what their wages are and what their constant fight is with their employer. It's usually over healthcare benefits, right? When you do your negotiations. The other part is that it's probably kept wages much more stagnant than they could have been had they freed up the healthcare. But we have some unions here in the state of California that are playing both sides. And particularly some of our healthcare unions that are affiliated with Kaiser or some of the hospitals, they want Medicare for all on one hand, but they don't want to do anything publicly to piss off their employer. If they support a Medicare for all bill, does that really jeopardize their contract, say with Kaiser next year? And so I think that it's a very, unions are not this, as you all know, homogeneous group, right? You sometimes can have unions that don't talk to each other, but they're an essential part to move this forward. Absolutely.
Just to plug previous span talk, actually, we have a great talk about unions and the fight for single payer from earlier this summer that's on the span YouTube page if anybody missed that one. Next up, we have a question from Alyssa Otieno. You can go ahead and unmute yourself.
Hi, thank you. I appreciate this talk and finding out about it on social media somehow, but I have a question about what will happen to ICD codes, diagnosis codes, because a lot of times even Medicare is still restricting access to therapies that work. Especially I'm from Minnesota originally and grew up under Wellstone, where we had this fight for parity and mental health care for all, but you don't see that even in Medicare. And so I sometimes struggle with Medicare for all when my experience and a lot of people I know's experience with Medicare needs to be improved. It's not, right. There's still a lot of issues. Of course, a lot of that was touched on with Medicare Advantage, but even Medicare alone. So I was just wondering how diagnosis codes will work.
Well, a couple things. One, I was a huge fan of Senator Wellstone, a huge loss in our country. Secondly, I think it's very important that you realize that current Medicare, it's better than a lot of the private insurance, but it doesn't go far enough. And I know a lot of seniors who are on Medicare who are struggling because it only does cover a limited amount. And so when we say Medicare for all, we're not talking about the existing Medicare as is. It's an improved Medicare for all that we're really talking about. Now, ICD-9 codes, whether or not we're going to do away with fee for service, all of those things are up for debate. I would say that we will need to do some sort of coding regardless. It's not so much the coding, I would argue, that is the problem. So ICD-9 codes is when I see a patient and diagnose the patient, and then the procedures and everything, there's a specific coding for everything about that, from the medical condition to the medications, the treatment plan, all of that. There's specific coding that we need to put in, and basically that's put into a system to keep track of, try to keep track of it. It's very complicated. And again, we should simplify that. But that's, I think, less of what is the problem. The issue is still the reimbursements for a lot of the procedures. Now, Medicare is far better in terms of approving things than the private insurance industry. Many things that Medicare covers far more things than private insurance industry. Now, does it deny some things? Sure. One of the things that people are questioning is the new Alzheimer's drug that was just approved by the FDA, the controversial one. Medicare, it's not clear whether or not they're going to approve that because the data is strictly not there yet. I think the difference, though, between Medicare denying something and the private insurance industry denying something, it's really going to be based on real medical data and medical expertise versus when a private insurance industry denies something and replaces your drugs and gives you a cheaper alternative, it's always based on cost. And many times they go against the standard guidelines that physicians have been trained to follow.
Thank you. And I guess if I can follow up, some of what I'm speaking about is things that just get completely denied for any insurance. Like there's treatments that are a little bit more creative in terms of like dealing with trauma. There's something called somatic experiencing therapy. Well, at least in the state of North Carolina, no insurance is allowed to cover that. And so that's why you see medical providers stepping out of this whole system of having to prove a diagnosis. And then along with diagnosis, that can be leading to why there's so many different misdiagnosis in the mental health world, because after 15 minutes, they have to diagnose somebody. And then they put them on this treatment that then turns into 3 more mental health diagnoses. And so I guess it does kind of go outside of Medicare for all, but I do feel like,
but I will say this, that any treatment, and there are a lot more treatments that I think would be covered under Medicare for all, a lot of alternative medicines, things of that nature, but it has to be evidence-based. And I would say that there are a lot of treatments out there that claim to do things. And then, like, as an oncologist, I used to see patients go down to Mexico and do some experimental treatments, and I was all in favor of it. But when I would call the doctor and ask for the real medical literature, there was never anything behind it. So whatever treatments that you're mentioning, if somebody can do a careful peer-reviewed study and publish it, at least I think that in a Medicare for all system, it would be approved if the data supports it versus an insurance industry doing it strictly on cost. So I think there has to be real, objectivity and compassion, but also I think a lot more things would be available and reviewable for treatment under a Medicare for all system, and especially mental health, which is chronically and grossly ignored and underfunded in terms of providing care, treatments. A lot of the everything from psilocybin to things of that nature that are now being shown to prove tremendous benefit in mental health. Those studies are underway right now, and those studies, once they're peer reviewed, if they really show that it works, and I think it will be reimbursed under Medicare for all.
thank you.
Next up, I think we have Tim Bruce. Tim, go ahead.
Paul, if we had a public option in place, would we be in a better position to eventually achieve Medicare for all?
Great question. So it depends on the public option. If the public option were being allowed to buy into the existing Medicare system, just paying cash. So let's say right now there's a plan for Bernie to make it 60 and older to be eligible, but let's say that was the de facto public option, which I would love to see. So if you were less than 60 years of age and you wanted to buy in, let's say you were self-employed and you wanted to plan, I'd rather give the money to Medicare than to one of these big insurance companies. That would be, I think, something that would be fine. The concern about adding just a public option is there's a rumor that it would actually be administered by a private insurance plan, very much like Medicare Advantage. And that would just add one additional layer of complexity to the system and not address the existing shortfalls that I mentioned. But if you allowed people to buy into Medicare, which I would gladly do, then I think you could potentially make Medicare stronger because you're bringing in a whole group of younger, technically healthier people into a system to spread out the overall risk. At the same time, you would be strengthening Medicare, not the private insurance industry. So it's a great question, but I do think most of the public option plans that are being touted are not what I'm hoping for with Medicare, and it would further just add another layer of complexity and not solve any of the issues.
All right, thanks. Next up, Dee Chavez, go ahead.
Okay. Dr. Song, thank you very much. I've taken oodles of notes from your talk. I have two questions. One is a follow-up on what Bill Davis asked you about whether doctors would be reimbursed as much. I'm wondering about how hospitals would be affected in terms of reimbursement, and also, whether how we can convince them that this would be good for them. That's
Great
the first
question.
question.
So as I showed you the slide before, hospitals like Duke University have more billing administrators than hospital beds, and they spend roughly $1 out of $4 of a quarter of each dollar on administrative costs. So that amount of money would the amount of money they'd have to spend on administrative costs would dramatically drop down, and they would actually have more money for profit or for for capital improvements to the center. One thing you will hear the hospital association say is that a Medicare for all system, they couldn't afford it. And that's simply not true. The majority of the hospitals in the United States, I'm not talking about like the Cleveland Clinics or, the Cedars-Sinais that are flagships that draw people in from all over, the state or beyond. Those hospitals are going to do well no matter what the reimbursement is, because they're cash cows. They make a lot of money, not just from private insurance, but a lot of people from international countries that'll fly and pay full price or 3 times the price to see care. But if you look at a lot of the community hospitals, particularly those that have to take care of uninsured or Medicaid patients, they would come out ahead under this plan. And you see a lot of rural hospitals closing because the people they're taking care of can't pay their bills. And this would actually cause more hospitals to remain open in desperately needed areas so that people wouldn't have to drive 100 miles to get to the closest hospital because the one in their community closed down. So would some hospitals make less money? Sure. But would it make it to the point where they couldn't survive? No.
No. Okay, thank you. And my second question, we've been talking about this a lot in our group lately, that we need the business community on board before we're going to make this happen. And so I wonder what you would say what we can do to reach out to that segment.
I will say that certainly under the Affordable Care Act, they still made it so businesses that had less than 50 employees didn't have to cover healthcare benefits for their employees. But if you look at the companies that are 50 or more, healthcare eating up a big portion of their budget, and they can't hire as many people. They can't pay the wages that they need to. And for the big companies, they can't spend money on capital improvements, building out infrastructure, R&D. All of that is capital that would be freed up under a single payer plan. For small businesses, though, many people are afraid to start their own businesses because they're trying to figure out, how am I going to cover my own healthcare? So if they're now given, if you have your coverage, then you don't need to stay in your job that you don't necessarily want. You can take the risk of trying to go start your own business because you don't have to worry about healthcare benefits. I think the biggest thing to realize is most countries cover health coverage for their employees, for their citizens. So, prior to the bailout, General Motors spent more money on healthcare for their retirees and their employees than they did on steel to make cars. Imagine if they didn't have to cover healthcare benefits for any of their employees or the retirees, how much more money they could use to build out, and research and development and attract more people through higher wages. I think that somehow the Chamber of Commerce has been co-opted by the private insurance industry, and they need to realize that the insurance industry is not the business's friend. If anything, it's a bigger cost than they need, and that's what we have to do. Is we have to decouple the Chamber of Commerce from the private insurance industry and realize that their interests are not aligned.
And do you agree that we have to get business on board generally?
Oh, absolutely. And I know that there are business leaders. And Wendell Potter has been really speaking to the business leaders and small businesses about how detrimental their healthcare costs are to their businesses. And how if they didn't have that, they would actually be a much more profitable business.
Yeah. Thank you.
All right. Next up, we have Brad Cotton. Dr. Cotton, go ahead.
Paul, first of all, I appreciate your comments on evidence-based medicine. I mean, obviously, we have to have particularly in these days of all the anti-vax information, we have to stick with the facts. In fact, as an emergency physician now semi-retired in urgent care, I tell people I treat you based upon facts and science, not based upon the latest YouTube video I just saw. So we strictly got to be evidence-based. In fact, the whole argument for Medicare for all is got to be evidence-based. And I had my hand up for a long time simply to, in fact, make the point that yourself and Dee just made. That is, it's not just physicians who will actually do better under Medicare for all because they don't have to have all those 4 or 5 people in their office fighting with 4 or 5 people in the insurance company all getting paid. But Duke University no longer has to have almost 2 people per hospital bed, wasting all that time in billing. You showed the chart on the growth of administrators and physicians that it's better. And it's the hospitals, at least in my area, what I saw that really went up in arms about we can't have Medicare for all, we can't survive. Beth Workman just had a comment here on the emails about that, but it's actually a boon to hospitals. With Jayapal's plan perhaps even being better and that hospitals are globally budgeted, then Sanders preserves the fee for service system for hospitals. But thank you for speaking today. And certainly Dee has worked very hard, and as our Gerald Freeman, who did our study of Ohio single payer, showed the businesses actually would have less expenditures for healthcare than they do now. So all the evidence points for this. It's just this horrible prejudice that government is bad and business is always better that fuels all this.
Well, again, thank you, Dr. Cotton, for that. And the other thing I failed to mention is that physicians, one of the other costs that would go away is malpractice insurance. So one of the biggest reasons malpractice tends to be high is that if you screw up, you have to pay for that person's healthcare for the rest of their lives. And if they have Medicare for all, they're covered. So you don't have to, insurance companies wouldn't have to worry about paying for that person's health insurance for the rest of their lives. So we've seen in countries where there is a plan like that, medical malpractice rates are a fraction of what they are here in the United States as well. But I'd love to have you, Brad, to speak more, through PNHP and really get you out in Ohio. So thank you.
Thank you.
All right. And next up, we have Kevin Henshold again. Go ahead.
Hi, thanks for letting me go multiple times. Real quick, what happens to the private insurance companies once we do Medicare for all?
So I think that certainly there'll be some transition. The feeling is that in reality, there still could be a role for them as a supplemental. A lot of those people can be reached, and every bill that I've seen has retraining to allow those people to do other roles and such. So, obviously the medical industrial complex is massive in our country, and we don't want to now all of a sudden leave people without jobs. A lot of these people are talented, smart, can do multiple positions. But I do think there would be a role for some sort of supplemental. If you look at countries that have a single payer system, Korea, Taiwan, R2, Canada, there is a role for supplemental insurance for people to then use that. The idea behind Medicare for all, look, do I think Medicare for all is going to be 100% perfect? No, there is no perfect insurance. But the fact that nobody in a Medicare for all country goes bankrupt when they get sick or is denied care is really at the core of what that sets you apart. But will there be providers that don't participate in it at all? Sure. And would there be some role for a supplemental to get into something that maybe is not fully covered? Yes, but all those logistics have to be worked out. The biggest thing about Medicare would be a certain basic high quality coverage that we all have, regardless of our ability to pay, and that would protect us at the time that we need it the most. That's really what it's the most crucial element.
As far as the insurance companies and the people that work for them, we had a speaker on our union program who talked about just and fair transitions. And I put the link to that program from our YouTube page in the chat, and you can go to that and you can listen to it. We had 3 great speakers. We had Katha Fortier from the Unifor, Canada's one of Canada's largest public unions, and we had Rhiannon Duryea from the Labor Campaign for Single Payer talking about labor issues here in the U.S. And then we had Catherine Isaac from the Deb Jones Douglas Institute who talked about just transition, and she dealt with the issues of the insurance companies and the workers. Now, we don't really worry about the CEOs because they've made their millions and they'll be fine and that, but it's the claims adjusters and so forth and that type of thing, that they're just people that are trying to feed their families like the rest of us are. And yes, we need to provide for them. But don't worry about the insurance companies. They know that eventually this is happening, and they've been diversifying and buying up other issues and that kind of stuff. They will land on their feet without too much difficulty. They might have to scramble a little bit, and if they do, that's good for them because they have helped create this whole mess.
If I can clarify, yeah, obviously workers need a just transition. I guess I was talking more about shareholders, just because people are going to say, oh, retired people have bought into shares, or just because, we're a capitalist country, capital controls stuff, the shareholders have capital, they're going to have a lot more influence than the workers. I know the companies like to use the workers as a shield and say, you can't hurt these people, but do we have to buy the companies out? Can they just say, hey, private insurance is no longer allowed for these things Medicare covers? I guess what are the options, and then in terms of feasibility, cost, and then political possibilities? And I realize it's kind of a weird question, but
again, it's not an area I'm as well versed in. I will say that when I look at some other companies in the last 10 years that had huge market caps that are no longer really there, it's inevitable that there are certain services and things that really go out of vogue. I mean, prime example I would say is the disposable cameras and Kodak, right? And now everyone buys a camera and they use their cell phone. And as a company like that was on the Fortune 500 is no longer there, and their workers had to be retrained. At least there's legislation here to allow the workers to be retrained and not displaced and just thrown out on the street. That you want to use a lot of their talents, fine tune it, and move it into other sectors. But that is, those are all. It's a big process. But I know that Pramila Jayapal has really been thoughtful about all of that into her legislation, and they would certainly take that into consideration.
All right, and next up we have Pam Cobb with a question. Go ahead.
Paul, my name is Pam Cobb. I'm a family practitioner here in Ohio, and I was looking at some statistics, and it looks like about almost 50% of our healthcare in this country is paid by the government. If you look at Medicaid, Medicare, the Veterans Administration, the Indian Health Service, all of that. So what do we need to do to convince our friends and patients that we only have another 50% to go, and this is to their benefit? Thank you.
Great question, Pam. Actually, it's more. There was a study that was done by David Himmelstein and Steffi Wohlhandler, who are professors at in New York, and they found that for every healthcare dollar spent in the United States, 68 cents of every healthcare dollar is paid for by us, the taxpayers, not just in terms of tax breaks to Apple and Google to provide healthcare to their employees, but for every state employee, every teacher, every firefighter, and then to mention Medicare and such, S-chip. So if you take all that money together, it's actually 68 cents of every healthcare dollar spent. And we know that the private insurance industry currently wastes somewhere between, it used to be a third, but it's rough 12 to 15 cents of every healthcare dollar on administrative costs, advertising, lobbying, things of that nature. The money is there. As I mentioned, the Mercatus study showed that Medicare for All plan over the next 10 years would save $2 trillion. So, I would argue, as you mentioned, we're essentially paying for a universal healthcare system. We're just not getting it because you have all these people that are leeching their pound of flesh for their own profits and administrative waste. So between that and the bulk discounts that we would negotiate, the money is there. That's the sad part.
Okay, Paul, we want to thank you so much for this. You've done a wonderful job. You've really given us a lot of great things to think about and that. So, again, thank you. And how do you want to go about sharing the slideshow with us?
I will email it to you, and then
Okay.
feel free to, you know what, actually, let me see if I can put it in the file now.
Okay.
While he's doing that, I just wanted to mention for anybody who isn't aware that you can go to our website at spanohio.org to join the email list so you can find out about upcoming events that SPAN is having around the area. You can also find your regional coordinator there. So there's somebody in all the corners of Ohio that can get you in touch with local events and local planning. And make sure you get involved. As Deb said, this doesn't happen unless we're all involved and working on the ground. So thanks so much for everybody for coming, and thank you, Dr. Song.
Oh, you're welcome. You know what? For some reason, I can't share it here, but I'll send it to you, and feel free to share. And again, thank you so much for taking time to listen today, and I appreciate all the work you guys are all doing too.